Hi all of you. In this video, let's see about serum anion gap and urine anion gap. Right. So let's start with the question. A 30-year-old female admitted with a history of bulimia and low BMI, and she was worked up, and she got the following lab results. So the pH was 7.29. The normal pH level is the normal blood pH is 7.34 to 7.44. Now the bicarbonate level was 50 milliequivalents per liter. The normal bicarbonate level would be 22 to 26 milliequivalents per liter. Now the PCO2 of this female was 31 millimeter mercury. The normal would be about 34 to 44 millimeter mercury. Right? So here, what do you find with these three values? You find that the pH is decreased. Is it not? The pH is decreased. So which means that there is acidosis. So if there is acidosis, what would be your next step to find out whether it's a metabolic acidosis or respiratory acidosis? So if reduced pH, if decrease in pH is associated with a decrease in bicarbonate, yes, if the pH is less and your bicarbonate level is also less, then you call it as metabolic acidosis, right? So if the decrease in pH is combined with a increase in PCO2, then you call it as respiratory acidosis. Yes, you call it as the respiratory cause for acidosis. Now here in this question, what do you find? You find a decrease in pH with a decrease in bicarbonate. Is it not? And your PCO2 is also decreased. So here decrease in PCO2 will not attribute to acidosis. So here it is a metabolic acidosis. So once you found out that it is metabolic acidosis, the next step would be to find out the anion gap. Okay. So because depending upon the anion gap, based on the anion gap, you have two types of metabolic acidosis, which is high anion gap metabolic acidosis and a normal anion gap metabolic acidosis. Right? So before that, what is anion gap? Before calculating the anion gap, let's see what is anion gap. In a biological system, all cations would be equal to the sum of all cations would be equal to sum of all anions. Now, what are the major cations? Sodium is a major cation with potassium and unmeasured cations, which is equal to the major anions would be bicarbonate plus chloride plus unmeasured anions. Is it not? Now, when you rearrange this equation, you find that unmeasured anions minus unmeasured cations would be sodium plus potassium minus bicarbonate plus chloride. Yes, minus bicarbonate plus chloride. Now, what do you find? The anion gap is nothing but the difference between the unmeasured anions and the unmeasured cations in your body. So when you calculate the anion gap in this case, what happens is 143 minus 120 plus 15. Is it not? So which is 143 minus 135, right? So 143 minus 135 will be 8. Right? So here the anion gap is not increased, which means that this is a case of normal anion gap metabolic acidosis. Yes, this is a case of normal anion gap metabolic acidosis. Now, what can be the causes of normal anion gap metabolic acidosis? So, whenever your anion gap is normal, okay, it can be due to two reasons. One reason is it is mostly due to loss of bicarbonate either through the GI tract or through the renal tract. Yes, there is loss of bicarbonate either through the GI tract or through the renal tract. Now, the loss of bicarbonate through GI tract, the example can be diarrhea. Through renal tract, the example can be renal tubular acidosis. Okay, the example can be renal tubular acidosis. Now, this normal anion gap metabolic acidosis will be also called as hyperchloremic metabolic acidosis because there is loss of bicarbonate. To maintain electrical neutrality, your chloride levels will be reabsorbed. Your chloride ions will be reabsorbed. That is why there is hyperchloremia in case of normal anion gap metabolic acidosis. Now again, to distinguish the cause, whether it is whether the loss of bicarbonate is due to GI cause or renal cause, you have one more parameter, which is the urinary anion gap, right? Urinary anion gap. Now here, the again it is the same, the unmeasured anions. It's a difference between the urinary unmeasured anions and the cations. So which is given by the formula sodium plus potassium minus chloride, right? Bicarbonate is almost reabsorbed, it should be reabsorbed. Okay, so that is why the urinary anion gap will be sodium plus potassium minus chloride. Now, if the urinary anion gap, yes, if the urinary anion gap is negative, right? If the urinary anion gap is negative, then that is a GI cause. Okay, that is it. That will be a GI cause of normal anion gap, metabolic acidosis. If the urinary anion gap is positive, then that will be the renal cause of normal anion gap, metabolic acidosis. Yes, so negative urinary anion gap indicates GI cause like diarrhea, and positive urinary anion gap indicates renal cause, which can be renal tubular acidosis. Alright, now let's see how the urinary anion gap can be negative or positive. Okay, now what happens in case of acidosis? So now all that we are talking about is metabolic acidosis. Right. So in response to acidosis, in response in diarrhea, let's take diarrhea. In diarrhea, what happens? There is loss of electrolytes through the GI tract. Yes, there is loss of electrolytes through the GI tract, which means that your kidney is functioning normally, which means that your kidney is functioning normally. So what happens here in response to excess H plus ions, that is in response to acidosis, your kidneys will try to remove the H plus ions. Yes, your kidney will try to remove the H plus ions. So now this H plus ions in urine will combine with ammonia. Yes, it will combine with ammonia to form ammonium ions that can combine with chloride and it can be excreted. Right, so the urine is in the urine, the H plus ion, how it is excreted out in response to acidosis, the excess H plus ions is excreted through your kidneys in combination with ammonia, forming ammonium ions. Right? So as ammonium chloride, it can be excreted. As ammonium chloride, it can be excreted. So now when you see the urinary anion gap, it is sodium plus potassium minus chloride is what, only these three parameters we have included in this urinary anion gap. Now we have this ammonium ions which is excreted in the urine. So this is an unmeasured cation, is it not? So because of that, the H plus, there is a H plus sodium exchanger. So sodium gets reabsorbed in exchange for H plus. So your ammonium unmeasured cation is increased. So in response to that, your sodium levels will be decreased. Yes, your chloride levels will also be increased. Yes, your chloride levels will also be increased because as ammonium chloride, your H plus is excreted. Right? So if the chloride ions are increased and sodium and potassium ions are decreased, then what happens? This urinary anion gap will get a negative value. Is it not? It gets a negative value. So this is the reason why in renal cause, sorry, in gut cause or the GI cause, you get a negative value, negative urinary anion gap. Right. So now what happens in a renal cause? The renal cause, what have we said? It is renal tubular acidosis. Right. So renal tubular acidosis, there are type 1 renal tubular, which is distal renal tubular acidosis. Type 2 is proximal renal tubular acidosis. And there is type 4, which is due to increased aldosterone. Right? So, the cause of this renal tubular acidosis causing metabolic acidosis is decreased acidification of urine, decrease in the acidifying capacity of urine. Okay, which means that H plus is not properly excreted in case of distal renal tubular acidosis. In proximal, there is decreased reabsorption of bicarbonate. So the bicarbonate is not properly reabsorbed, right? So here it is either due to decreased excretion of H plus or decreased reabsorption of bicarbonate. These are the two main causes of type 1 and type 2 renal tubular acidosis. Now what happens in this renal cell? The kidney is not functioning properly in case of the renal tubular acidosis. So your H plus is not coming out, right? So if your H plus is not getting excreted, your ammonium ions are less. Is it not? Your ammonium ions are reduced. Yes, your chloride ions will also be reduced. So in which case, what do you find? What do you find in urinary anion gap, which is sodium plus potassium minus chloride? Yes, your chloride is less, is it not? So which means you get a positive urinary anion gap. You get a positive urinary anion gap. Now if you calculate the urinary anion gap in this case, what do you find in this case? Sodium is 18 plus potassium is 8 minus 32. So what do you find? It is 26 minus 32, right? So you get minus 6. So it is a minus 6 is a negative value. So negative value, which means probable cause would be the GI cause. Is it not? Probable cause would be the GI cause. Now here, so you can straight away, so you have these four options here. One is laxative abuse, vomiting, distal renal tubular acidosis and proximal renal tubular acidosis. So since your urinary anion gap is negative, yes, since it is negative, you can rule out these last two options, renal tubular acidosis. Right. And then there is vomiting and laxative abuse. In vomiting, what do you find? You find metabolic alkalosis. Yes, vomiting, you find metabolic alkalosis. So here it is the laxative abuse which can be the cause of diarrhea, which can be the cause of, yes, laxative abuse, which can be the cause of your metabolic acidosis, right? So even in this history, what do you find? You find a 30-year-old female with history of bulimia and low BMI, which can be, so in these kind of patients, there can be laxative abuse or diuretic abuse, yes, to maintain their BMI, right? So that can be the cause. Laxative abuse is the answer here. All right. So thus we've seen about serum anion gap, urine anion gap, and how you can use them in diagnosis, right?